Thanks very much for joining us here today. Before I begin, I'd like to acknowledge the traditional owners of the land and pay respects to their elders past and present for the land on which we stand and present today. My name is Avi Ratnanason. I'm the CEO of MES, and we're an organization that specializes in measuring and improving patient experience. For the next 20 minutes, you'll hear about a platform that is now an Australian first, in the way that it's customized for a healthcare environment in terms of measuring and improving the patient experience. This is now going to be the most advanced technology in patient feedback collection and analyzing patient emotions, such that those insights can contribute to new opportunities and solutions for evolving healthcare facilities in this great country. Whilst there are challenging times ahead in healthcare, and the sensitive economic environment and the stringent financial targets that we face as managers, many organizations in our health system are still continuing to work very hard to deliver the healthcare experience that's requested and demanded by the patients in Australia. Along with that challenge though, some people say that Australia is about 3 to 5 years behind countries such as the US and the UK in terms of our capability to truly understand patient needs and use them for health system transformation. So it's true that in some respects we may be considered a little bit early in the journey of patient-centered care, particularly as defined by patients themselves. In fact, some people would say that patient-centered care in Australia is more defined like this. And therefore, there's a disconnect between what health professionals, executives, even policymakers decide is patient-centered care versus what patients themselves decide is appropriate for them. And it is really that disconnect that we're looking to fix up with this solution that we're presenting today. We can't forget that our health system is this enigmatic machinery for us to deliver care to those who are weak and suffering, but that our health system is also the symbol of our humanity. And so to evolve that sense of service and humanity, what we really need to do is really close that gap between those right at the top of our health system with the patients and staff right at the front line, and get really deep into understanding their needs, their thoughts, emotions, and feelings as they go through the health journey. Indeed, in our work at NHS, at advising organizations to use data and insights to improve patient experience, we believe in helping healthcare transform via the 3 T's. That is, essentially, technology, thought leadership, and training. And we feel that in today's environment, you need a combination of the 3 to really make change. The good thing is, Australia now has the opportunity to learn from the mistakes of other countries. We can innovate and we can win that race to become the best, most patient-centered health system in the world. We certainly have the ability to achieve that goal, and in my 20 years in healthcare, I've noted that we have some of the best people in healthcare in the Australian health system, some of whom are in the room today. So thank you very much for coming. With the Turnbull government's Ideas Boom campaign and the renewed innovation agenda, history has shown that time and time again, that is in these constrained environments and the constrained financial situations that we have, it is in these environments that innovation thrives. It is in these constrained environments where the seeds of opportunity are sown, and it's in these constrained environments, true patient insights and customer-centered care is going to bring about that impetus for change. So perhaps all we need is a change of perspective here in Australia. Perhaps what we need is not more action, but the right actions resulting from intelligent dialogue, data, and a diversity of perspectives from all the different healthcare stakeholders, particularly patients. As such, all we need to do is keep our hearts and minds open to the different perspectives that may aid in the future health and well-being of this great country. That future of a new and improved Australian patient experience really starts today. And so what I'd like to do next is invite a new perspective, a different perspective, a perspective from the UK. I'd like to invite Nick Goodman, the Director of MES, or Membership Engagement Services, up to the stage. Now, a little bit about Nick and MES. NHS has formed a partnership with MES in order to bring some of that technology, thought leadership and training to the Australian healthcare environment. And Nick's background as Director of MES, where they've worked with over 170 NHS organizations, learning about how patient-centered care works. Nick's going to tell us about the mistakes they've made in the UK and how Australia doesn't have to repeat them, particularly with the new MES Experience platform that they're bringing about. Please give him a warm round of applause. Thanks, Nick.
Good, thank you. Thanks, everyone. Yeah, I'm Nick from London, fresh in. Thanks for bringing the weather. So thanks to Avi for that introduction. I'm going to spend a little bit of time just chatting about, give you a bit of a background about me and the company I set up, and then go into the patient experience situation in the UK and what's going on there, and then we'll throw it back to Avi and try and link up with the Australian situation as well. So very quickly about me, I'm from a democracy and enabling background. Thank you very much. So I started life helping organise elections and ballots for organisations. About 10 or 15 years ago, there was a new model introduced in healthcare in the UK, which very much put members at the centre of hospitals. So hospitals all of a sudden had to go out and get members and start engaging with them and talking to them about what they wanted from their hospital services, involving them in redesign and so on. And that's become really the way that the health model in England today. So I set membership engagement services up, and it very much does what it says on the tin. We don't work exclusively in healthcare, but we're very dominant in it. And good engagement is really where we're coming from. We weren't set up as a software house that had a good bit of kit that we wanted to sell into the health sector. It was really about providing consultancy and services to help organisations connect better with their members and their patients in healthcare. So we start with people. That's our number one in what's important to us on our website and our philosophy. And then we design and enable processes and quality systems to improve the conversations that we can have amongst the people. So we now, 10 years on, we've been going for a decade, we now work with 170 different NHS organisations, providing membership management and engagement support and patient experience services. We're now the market leader in the health sector in England. We have great stickiness. Clients like working with us. They like what we do. We deliver what we say, and we deliver it on time and to budget. We have clear and transparent pricing. Incredible customer service is our biggest focus, and it works. And I've got a great team of 23 back in London. We're also trying to operate more than just a business and a supplier to the sector. We're a thought leader as well. We've written research and articles. We endeavour to inform, guide, and at times lead our sector too. Without trying to claim credit for the word engagement, I will say though that before MES, this was not common terminology in the health sector. Now you can't read an article about the health sector in the UK without reading the word engagement, and that it's going on in so many departments across the health sector. In July 2010, we'll be marking our 10th anniversary with our first own full conference, Challenge 2020. So if you are in London, please come along. So a bit about patient experience in the UK, and the context is important to note, which is why I've talked a little bit about the history of membership and how people have been very much involved in the health sector over the last decade or more. And that followed Foundation Trust legislation for those of you who are more informed about that area. There were other things that happened as well. So there was the mid-staffs situation, which I won't go into detail, but serious failings in care and higher mortality rates, which caused a renewed look at what was happening in trusts behind the financials and a new renewed focus on transparency and listening to what people were actually saying on the ground. There was a new NHS constitution launched in 2009, and that has 7 guiding principles, 2 of which could not be clearer on the importance of informed decision making. Those 2 principles being that the patient will be at the heart of everything the NHS does, and that the NHS is accountable to patients, communities, and the patients they serve. There was then a 2012 government white paper, Liberating the NHS, which was entitled No Decision About Me Without Me. Again, renewing the focus on the patient being right at the centre of decision making. Patient experience managers, patient directors, patient experience leads. These very focused roles that now in the UK we're taking for granted, they didn't exist even 3 years ago. There were maybe a handful of them. There were plenty of staff dealing with public and patient complaints, but there's no one really focused on listening to what the feedback of the patient is. So it's a massive agenda in the UK, finding out what is happening on the ground and what people are finding their care and their experience to be, their feelings, and then using this experience to drive quality improvement and greater efficiencies, partly through speedier response times, which we'll get onto later. And these are essential, and it's central to how hospitals in England are now operating. Friends and family testing, or net promoter scoring as it's often phrased outside of the UK. This is now big activity in any trust in any hospital that you might visit in England. So just as with previous engagement and involvement models, hospitals are required to report certain aspects, and a lot of data is collected for the Department of Health, the Care Quality Commission, and their own boards. This is ensuring that patient experience remains an absolute focus for hospitals. Avi was wanting me to talk about some of the lessons learnt. I would say that there are undoubtedly problems. There is not consistency across the sector. Budgets are meaning that staff are stretched, and a major piece of research that we published last year found out that there is a significant problem with bureaucracy and the volume of data that is being collected and fed into the system. Staff are finding that they're spending so much time focused on the process of collecting and reporting data, there's not enough time to then do anything with the findings. And that's definitely a learning point. So they're simply feeding the beast. So you'll hear more from me later about that, but I'll hand over to Avi again to talk about the Australian situation a bit more.
So as Nick was pointing out, the situation in the UK is slightly more evolved, or quite significantly more evolved compared to Australia in terms of how they manage patient experience. But in our experience, talking to a lot of patient experience managers, directors, CEOs in the Australian healthcare environment, there are a number of challenges that we face here as a country in terms of how we collect and analyze this data. And a lot of this has come from just speaking to people on the ground and finding out what are the problems that they have. One of the majority of ways in which we collect patient feedback at the moment is through surveys, obviously. And those are often done at home via telephone, or they're paper-based. So we're still very much in that paper-based era of patient feedback collection in a lot of hospitals. The challenge with that, obviously, is aggregating that into something meaningful. It takes a lot of work, it takes a lot of time, and it's very difficult to use those insights intelligently. Okay? We do them, once we aggregate the data, they're in multiple different databases. So if you can imagine, some people use SurveyMonkey, somebody else has created their own survey, somebody else has gone off and used another database, and they're all sitting in different places. They're not tracked over a long period, so we don't know what improvements we're making. Everything's very disparate. The other issue is that the insights, as I said, are uncoordinated and unmanageable. In some areas, we've become so good at measuring that all we do is spend time measuring, because that ticks the box. And we don't actually know how to use that measure and action it intelligently. So even when you speak to people at Google, they'll tell you need 2 things to make better decisions. You need the ability to measure accurately, and then you need smart people to actually decipher what that measurement means and what to do with it. And we seem to have lost a bit of the latter. Often when we do the state-based surveys, which is great, it takes about 3 to 9 months for the results to come back to a hospital. That makes it very difficult to have real actionable insights and for staff to say, yep, the results of the survey is because of me. Because very often in that 3 to 9 months, staff would have moved on, senior management would have moved on, things would have got lost, and it's very difficult to say that the problem that occurred on those wards was because of me or my team. And therefore you can't really get action happening. The reports from board to ward, if you recall, if you really want to change patient experience, that means the people on the front line, the nursing staff, have to get certain types of reports. The people higher up in management need to get a more aggregated view. And the people higher up, the CEOs, the Ministry of Health, the Department of Health, need to get even bigger aggregated views. So you need to be able to grow broad and also deep dive at the same time. At the moment, we don't really have that ability because often the stuff collected on the ground is difficult to aggregate. Does that make sense? Yeah. One of the challenges with when you hire professional companies to do a lot of the surveys, internal staff tend to say, okay, well, somebody else did that. It's not my problem, right? Somebody else collected the surveys. Yes, you sent the results to me, but the lack of buy-in is a problem. And what we know about human psychology is that if a person is involved in the process, they're more likely to take action, right? So right now we are relying on expert survey companies to do the work, and that's fantastic. But is there a way in which staff themselves can get more engaged in the process? Yeah. And finally, when we talk about data, and we're moving into this world of big data, right? How many people here have heard the term big data? Yeah, everyone's talking about big data. Very often when people talk to you about big data, they're talking about numbers. They're talking about quantitative big data. Very rarely do people talk about qualitative big data, which is big data around the text. So not a lot of work has gone into really analyzing the text, which is the gold mine of understanding why a problem is occurring, right? So often your quantitative data tells you where the problem is occurring in the hospital, but the qualitative, the text part, tells you why the problem is occurring. Why is that important? Because if you understand why a problem is occurring, you can create a solution and fix the problem much better than if you just understood where. Does that make sense? So these were some of the problems. So one other problem is Australia, I don't know if you realize, is a multicultural country. We have a lot of ethnic minorities, and myself included, and we use different languages. However, in the survey process, we're largely surveying people in English, right? So we need to make this evolution where we actually start to incorporate surveys in other languages, but still gather those insights back into a central repository so we know where the problems are occurring in different parts of the hospital. Does that make sense? Yeah. So that leap is something that we need to make. So, as a result, from having all these discussions in Australia and having these conversations, what we did as NHS was go out and look for what is the best solution that we can bring to Australia to solve this problem for Australian hospitals, for Australian managers, for Australian CEOs. This is how we came about coming across Nick Goodman and his team at MES and the MES Experience solution. So what I'd like to do, Nick, if I could just hand over to you to talk a little bit more about the MES Experience solution and how that solves some of the problems that we've just talked about.
Yep. Okay, so just to kick off this section, it's important to remember something I said earlier, which is that the focus for us is developing the right tools, the processes and the systems to support our clients' needs, the hospital's needs, which is communicating better with their people, their patients, their staff, and so on. What we're not about is directing our clients to buy a particular product that kind of does what they want or does half the job. So they're very tailored and configurable to what our clients and our hospitals need to deliver the work. So what is MES Experience? It's an online patient experience capture and reporting system. So the first area to look at is that it has a multi-channel approach. So in the UK, an absolutely huge driver for us is to move people digitally and away from paper so that we can accommodate all feedback formats, as well as lowering the cost of the process of going out and getting the feedback. So people want to have a choice in how they have their say, and we need to meet them where they want us to meet them, not force them down an unnatural path. So to that end, by multi-channel, I obviously mean online solutions, kiosk and tablets, text messaging, automated telephone surveys, email, and yes, still the paper-based postcards and drop-off boxes as well. I keep hopping.
Yeah. So just to give you a bit of an example, these are some of what the old patient surveys look like and the files look like, and they're sitting on somebody's cupboard from the last 10 years with all the patient surveys. But now we're moving to not only allowing for that to happen, but also to doing it via the iPads, via the mobile phones, and the kiosks that currently exist in hospitals as well.
Yeah. And of course, people can still take part through a standard online portal themselves perhaps when they get home or as they're leaving the hospital. Okay, so the next key area is that the system can create granular reports from ward to board. So these reports are filterable, and they can go down to a very, very specific level. So perhaps a ward sister will want to see just what is going on in her ward on a particular day, or in a particular part of the ward, and she can do that. Alternatively, a chief exec or a clinical lead may want an overview of a particular part of the hospital, or just a very top-line view. So the system can be configured to a variety of users and their needs. The screen just shows a couple of examples of the kind of dashboards that might be more suitable for a more senior person wanting just an overview, down to quite detailed alerts. So green and red showing the alert status.
I think one thing to point out as well, Nick, is that, just going back, is that you can basically enter whatever questions you want. And what we're finding is that while in patient experience, the Picker Institute tends to be one of the world leaders in determining what questions you should ask in terms of patient experience, when you go to different parts of a hospital, whether that's intensive care, you go into the surgical wards or maternity wards, different managers want to actually enter their own questions. So this platform actually has the ability for you to create surveys with your own questions, your own targeted questions that are specific to those particular units.
Trends and benchmarking. So users and directors can monitor how things are going, how things compare to a week ago, a month ago, a year ago, so they can start building up a picture and getting a real sense of what the direction of travel is, and importantly, what the direction travel needs to be as well.
One of the things that we do a lot here is benchmarking between facilities, between health districts, to see how we compare. So often the health districts do know where they sit in terms of health patient experience. Some are in the bottom quartile, some are in the mid-range, some do better. So benchmarking is a very important way of understanding where an organization sits in terms of patient experience. Some of the advice we do give, though, is that the best benchmark is benchmark against yourself. So over time, you can see that you are tracking progress. And some of the tools that we'll show you helps you identify that.
Real-time feedback and alerts for frontline action. So absolutely key and a real biggie in terms of how our system is delivering some different information for our clients and hospitals. So real-time feedback with customizable reports and alerts that can be set up for different levels of users. This feedback can then be turned into faster reaction, and it can even produce the sort of "you said, we did" ward poster that you can see on the right-hand side. So that's an example of a poster that is created from the system that a ward sister or a manager can produce based on the feedback and input that they're getting in real time, and then they can go and put that up in their ward. And if you go to any hospital in the UK, you will see a lot of that stuff going on. Again, it's all part of the agenda following the sort of last decade's worth of activity I was talking about, where it's incredibly important to be showing good visibility for staff and patients and that there's action on the input that's the input that hospitals are getting.
Yeah. So just hang on that for a second, because as I mentioned, in the past it's been taking up to 3 to 9 months to get those results back. So what we can do now is when patients put the feedback in via the iPad, the laptops, the kiosks that are around the hospital, we can actually look at those really quickly. But also when a patient puts in something that's potentially a swear word, or they mention a doctor's name or a staff name, or there's something that triggers maybe abuse, those alerts will come up to the patient experience team or to the directors that have been notified in the system, and therefore they can action that very quickly. And we did a pilot in one of the health districts, and we were able to pick up a problem area very quickly and then sort of respond to it. And what's happening on the wards now, as Nick was mentioning, this "you said, we did" is very, very important, because it all talks about transparency. People want to know that when I gave the feedback, you did something about it, right? People want to know that. So now what you can do is automatically populate the "you said" part, the feedback part, and what is the action that you took. So on your wards, on your departments, on your units, they now have these sort of posters, ward posters, that show the action that you're taking, right? It might seem like a really simple sort of solution, but these are the things that change behavior on the ward, and these are the things that will change our healthcare system.
Some of the wards that I've visited back home, they also keep up the previous posters as well, so that again there's some benchmarking there, and there's some evidence of that they are doing what they said they would, and those kind of things are starting to make a difference. So surveys are flexible and configurable, and unlimited too. So over time, a bank of surveys and survey templates can be built up, and Avi touched on this earlier. Obviously, or maybe not obviously, but different languages are of course catered for as well. We also have an incredibly diverse population now in England, particularly in the larger urban areas, and so in some parts of the country we're needing to cater for up to 15 or 20 different languages. That's quite typical now. Okay, moving on. Another real key area that we're very proud of is that our platform doesn't just handle quantitative data. It looks at free text as well, and analyzes not just that text, but the context of that text. This sets it well apart from other approaches. E.g. the word cross. I had to cross it out. He was very cross and had an appalling manner. She was not at all cross and had such a great manner. I had to cross over to the other ward, which was a real pain. Analysing the context around those words that we're looking at makes for an improved data set, and ours includes that. And we have different lenses. So we've got their patient emotions and staff attitudes, word clouds as well. And looking into the detail, you can see that we can start measuring things like delight, excitement, happiness, anger, fear, to really enrich that look at the data. We also look at staff compassion and communication as well. And there's more lenses being created all the time that we're developing in partnership with our clients and our hospitals to give them exactly the information that they need.
If I could just touch on that, Nick. So a lot of research has been done by organizations such as the Cleveland Clinic around empathy and the value of empathy in healthcare. And so we're now able to measure some of that empathy through the objective feedback that comes through the text components itself of feedback.
Okay, we are being rushed along because we've got too much to say. If anyone wants to talk to me afterwards, I've got a bit of information about some of the actual differences this is making back home with some of the hospitals that we've been working with, so I'd be happy to chat you through that. There is a piece of research that I mentioned earlier that is available as a free download at the NHS site, or you can text the number there to receive a copy. And that was the first really clear look at what's going on the ground with patient experience in the UK, making sense and making use of patient experience data. And as I said, the top finding there was really, let's start doing something with the data and allow our staff the time to do something with it, and not just keep the process going. I think we might have to...
Well, we'll just run through the last couple of things, which is one of the things that really engages people nowadays is video, and also a lot of people in healthcare are starting to listen to podcasts. So one of the things that we've done is start up the Patient Experience channel as a video and podcast, so people can listen to and access this knowledge in different ways. Being the digital gurus that we are, we obviously try to be more creative with helping people learn this stuff. And we've also started a LinkedIn group called Patient Experience Australia. So if you want to join the conversation, you want to pick up tips on patient experience, you want to do it all for free. By the way, it's all free resources. Just log into the join, get onto LinkedIn, look for Patient Experience Australia and join the group. It's really targeted for health professionals that want to actually understand what is the latest information in this space. So we haven't got time for questions, but we are going to be around for the next few minutes in the next couple of days. So we'll gracefully move on. But I'd like to thank you very much for your attention, and please feel free to stick around to chat to Nick and myself. Nick is going to be here for the rest of this week as well. So if you want to pick Nick's brains on what they're doing in the UK, what are some of the errors, and get into some of the nitty-gritty, he'll be happy to chat to you as well. Thank you very much for coming.
Thank you.
Yeah.